Thanks, Will. Well, our first speaker is Professor Grant McArthur. Grant is a consultant medical oncologist. He's head of the Translational Research Group and head of Molecular Oncology Laboratory at the Peter MacCallum Cancer Centre. He's a fellow of the Royal Australian College of Physicians in Medical Oncology and holds a PhD in medical biology from Monash. No, not from Monash, I forget now. From Melbourne. Because Monash, he had his undergraduate degree. In 2005, he was a Dunlop Clinical Research Fellowship of the Cancer Council of Victoria. It's my pleasure to introduce to you Professor McArthur. Thank you.
Thank you very much, Ross, and an honour to be introduced by Ross. It makes me think, if you think about our great country of Australia, we have this wonderful game of Australian rules football, of which Ross is, of course, a legend of the game. And we also have the disease of melanoma, of which is such an important health problem in our country and what brings us all together today. Thank you to Melanoma Patients Australia. Congratulations on the information booklet, a great tool for everyone involved in the field of melanoma. Very good. All right, so my task this morning is to talk about the current state of play, if you like, of the surgical and medical treatment of melanoma. So I'll be simple, and there'll be some more complex concepts through the talk, but wherever possible, I'll try to be as simple as I can. So I think most of us know what melanoma is, but just a reminder, it's a cancer of melanocytes. So in all of our skin, there are these cells sitting at the base of our skin that make the melanin pigment, which makes our skin go dark. And this is a patient here who has a condition called vitiligo. Michael Jackson had this condition, where you get death of these melanocytes, loss of the melanocytes in the skin, and your skin goes pale. So that's what the normal role of these cells are, and they're the cells that get transformed or changed into melanoma to form a cancer. Just like virtually any cell in the body can become cancerous, so can these melanocytes. And the real problem with melanoma is that these cells sort of get away from their normally they're at the base of the skin here, the bottom layer of the skin, and they learn to move and they learn to get away from the bottom layer of the skin. And they so-called invade, in other words, they go into the deeper areas of the skin, or they can even go up into the top layers of the skin. And the pathologist uses that as one of the diagnostic criteria when they look down the microscope at a lump that's been, or a mole that's been cut out from the skin, as to whether it's melanoma. But this is the real problem of melanoma, that these cells can escape and move from their normal position. Now, a few facts and figures, and I already mentioned, really this is Australia's disease, highest rates in the world, along with New Zealand, of anywhere in the world. And in Australia, 1 in 18 of us will get a melanoma in our lifetime. Breast cancer risk is 1 in 16 Australians, if you put males and females together, so pretty similar rate. We hear a lot about breast cancer, but melanoma is almost as common. More common in men than women. 1 in 14 men, quite a striking statistic. 1 in 24 women in a lifetime. At the moment, there's about 11,000 cases of melanoma a year, and I see that Melanoma Patients Australia very appropriately are thinking forward, and that by 2020 that number is anticipated to be up towards 18,000 cases a year, so quite a common problem. And to me, thinking about melanoma as a global problem, working with people around the world to do something about it, the figure that really hits me hard is 6.4% of cases of melanoma worldwide are in this country. Okay, we're actually a very small country. You think about the might of population of India, China, Russia, Brazil, countries like this, and yet 6.4%, almost over 1 in 20 of the cases worldwide are actually in our small population base of Australia. Most common cancer in young people in our country, 10% of all cancers. Breast cancers is about 12% of all cancers, so very close. And we need to do better in this disease, because the rates of people dying from the disease across the whole population have actually gone up a little bit, particularly in men over the age of 60. Doing much better in younger people, but in men aged over 60, that's a problem. And this is showing some statistics for you in another way. It's an article I've just submitted for publication to a journal, and melanoma is lagging behind other cancers. So these are years from 1980 through to 2010 here. The last date is actually 2008. And you can see that these dashed lines here are Australia, United States. The mortality or deaths from all types of cancer are definitely reducing and reducing quite significantly. So that's fantastic for cancer as a whole. But these are the melanoma rates in the solid line. Well, we are well above the US, but you know, it's trending upwards a little bit rather than downwards like other cancers. So clearly we've got to do a lot more research and got to think a lot about public health aspects of melanoma. Now I just want to go in for the remainder of the time and just talk about the treatment of melanoma. So melanoma, we talk about stages, and I'll be going through the stages a lot, and that's something which I think everyone should important to understand. So we have primary melanoma, so-called stage 1 and 2. Nearly always, not exclusively, but nearly always, especially in our country, starts on the skin. Then it can spread to what we call regional metastases, which is lymph glands close to where it starts on the skin. So this cartoon here, the leg, that would be the groin, but if it's the arm, it can be under the armpit. If it's the head and neck area, it can be lymph glands in the neck. And then if the melanoma cells spread further, there's so-called distant metastases, and this can be at virtually almost anywhere in the body, and that's so-called stage 4. So stage 3 are the local lymph glands, stage 1 and 2 melanomas just in the skin. And this is very important because we've got lots of statistics, and the survival rates of melanoma are related a lot to stage. So stage 1, much better than stage 2. Stage 3, with those so-called regional lymph glands, worse, and then if it's spread to other distant sites in the body, the outcome is even worse again. So stage 1 is thin melanomas, stage 2, thicker melanomas in the skin, stage 3, melanomas spread to lymph glands, and stage 4 to spread to distant sites. So we start now to understand, you know, why this is happening, and we won't go into all the details, but we're now really mapping out all the changes that happen in these melanocyte cells to make them turn into melanoma and why they behave the way they are, which is really very, very important, because if you've got a problem, you've got to understand the cause of it in order to fix it. Very simple concept, and we're starting now to really get a real good idea of the cause, what goes wrong inside those cells, and that's leading to some better treatments now. All right, so how do we treat melanoma? So this shows you a melanoma on the skin. So initially it will be recognised as not looking right. That may be a patient themselves, it may be a general practitioner, may be a mole mapping clinic. Dermatologist or other specialists recognise, yeah, this looks a bit suspicious, could this be a melanoma? So you have what we call excisional biopsy. So local anaesthetic injected, you just cut out the abnormal area you can see, and then you send it off to the lab for the pathologist to have a look at down the microscope. Okay, and they will then assess it and see whether it's a melanoma. Now, if it's a melanoma, then the treatment for a primary melanoma of the skin, this is stage 1 and 2, is what we call wide local excision. So here shows you a surgical technique, often done under general anaesthetic, can be done under local, but quite often under general anaesthetic, because it actually involves cutting out quite a lot of skin around the melanoma and then sewing it up again. And then if you recall that little cartoon I showed you with the cells, the way they get away, they start to move around. The reason you do this is you want to get rid of any little cells that might have moved away from the primary melanoma. So that's why you do the wide local excision, and it has to be wider the deeper the melanoma, because that shows a greater tendency to spread. Okay, so stage 1 and 2 melanomas, just to remind you, that's thin and thick melanomas. You treat them with surgery, and surgery can definitely cure the disease. In Australia now, it's just over 90% of people that get a melanoma are cured. So I mean, I've sort of talked about some of the bad sides of melanoma, but in fact most people with melanoma do get cured. All right, so what about when it spreads to lymph glands? Well, This is someone's armpit, and this is an operation to remove lymph glands from the armpit. So this is so a surgeon will make an incision under the armpit and look at removing any involved lymph nodes. Here's a lymph node here that is being removed as a part of an operation. Now there's a technique called sentinel lymph node biopsy, which can be used to detect early spread into lymph glands, where you notice that there's a bit of a blue colour to this lump here. That's because a blue dye has been injected around a primary melanoma, and then that blue dye can tract up things called the lymphatics, little fluid-filled vessels, up to the lymph gland, and if you biopsy that you can see whether there's any cells that have spread, and that can be used to define the risk of the melanoma coming back or not. All right, so how do you treat melanoma that's in stage 3 or involving lymph glands? So if there's a lot of lymph glands involved or the cells start to spread outside the lymph glands, you can treat it with radiation after surgery to try to stop the melanoma from coming back. And a major Australian study just got published about 2 months ago showing that this really does work, that radiation can reduce the chances of the melanoma occurring in the lymph gland area where it was removed. And this is a radiotherapy machine, precision focused high doses of radiation to kill off melanoma cells. There's a treatment called interferon. A number of you will know about that. Interferon is a complex treatment. It's a protein that's injected intravenously or under the skin. This is a really sort of complex cartoon, but interferon is actually an interesting treatment because it sort of targets a lot of the cells that sit around melanoma cells, like blood vessels and immune cells, to change their function. And look, it can reduce the chance of melanoma coming back, but a lot of you will know it has a lot of side effects, and we're desperately looking for better tolerated treatments than interferon to stop melanoma coming back if it's involved in the lymph glands. All right, so that is stage 3, lymph gland involvement, so melanoma spread to lymph glands. Okay, so what about melanoma that's spread to distant sites? And that I'll talk about for the remainder of the time. So-called stage 4 melanoma, so this is melanoma that has spread to different places. Well, mostly it's drug treatment that's used. Sometimes we use radiotherapy and sometimes surgery. So where do we use surgery? So we use surgery for special sites that cause troubles when the lumps have spread, like the brain or the bowel. This is a lump in the bowel here, and that can give good symptomatic relief to remove those lumps with surgery. And if there's not very many lumps, some people can be cured with surgery even when it's spread to the distant site. So typically, and there's lots of debate here about exactly how many lumps you can remove by surgery, but typically 3 or less we certainly consider removing them with surgery, and some people will go on and be cured by that, even the melanoma spread. You can use radiotherapy for melanoma at distant sites, and that's mostly used very focused treatment for sites that are causing symptoms to relieve pain and things like that. But the mainstay really is drug therapy, because the principle is if cells have got away, you need to be able to kill them off no matter where they are. If you can give a drug that goes throughout the body, either intravenously or by a tablet, that's an effective way of treating the disease. Okay, so I just want to mention then for the last few minutes before questions, just about the new treatments that are now approved in Australia. It's good, we've got 2 new treatments that show some benefit in patients with advanced melanoma now approved in Australia. One is called treatments to the gene called BRAF. So BRAF is a protein that makes cells grow, and I'll show you a cartoon of that on the next slide. And there's a new drug called vemurafenib, another one called dabrafenib, that turn off this mutant protein, and this shows you melanoma cells growing in our lab, and if you treat them with one of these drugs you can kill them quite effectively. This has been quite effective in patients, so this shows a patient with a PET scan, and this big black thing here are melanoma lumps in the liver, and after 2 weeks of treatment there's no more glucose being taken up into the melanoma in the liver. So this has been, this BRAF treatment, quite successful. How does it work? This is the complicated science stuff. So BRAF is a mutated gene, and it makes certain proteins get turned on in the melanoma cells that makes the cells stay alive and makes them grow. And then if you turn off the BRAF, the opposite happens, the cells die, they stop growing. And this shows you one of the proteins in the cell called ERK that BRAF talks to. And all this brown stuff here is ERK being switched on, but after 2 weeks of treatment, it turns it off. And what's actually really interesting scientifically, see there's little bits of brown left here, so that's normal cells. So the drug doesn't actually turn off this ERK protein in the normal cells. These are blood vessel cells, but it certainly does in the melanoma. So that's been quite successful, and that's why it's now an approved treatment in Australia. Still waiting for the PBS to reimburse it. But the results for people with the most advanced stages of melanoma have been encouraging, with about 40% of people at 2 years still being alive, which for very advanced melanoma is pretty good. This is a so-called survival curve, right? So this is percentage of people that are still alive with time, and if you have these BRAF inhibitors, it's about 40% at 2 years, which is much better than chemotherapy, which tended to be like this curve here, with only normally about 10% of people still alive at 2 years in the most advanced cases. So definitely an advanced treatment. But a lot of people in the room will know that BRAF inhibitors don't work forever, that you can initially get response, shown here in this cartoon, a very rapid switch off of growth of the cells, but then they can start growing again, and there's been lots of research done to show that one way that happens is acquisition of a new gene mutation, and one of these is called NRAS. So there's lots of research going on there. This just shows you what happens. I showed you this before, brown stuff being switched off very effectively, but gets switched on again as the melanoma develops resistance, and there are now trials underway. Michael's going to talk to you about trials to overcome this. All right, so the other new treatment that's been approved in Australia is a treatment called Yervoy or ipilimumab. Very different. It's about turning on the immune system to fight melanoma. So what happens when melanomas grow in the body is they're clever and they learn to turn off an immune response towards them. And there's been lots of advances in understanding why the immune system is turned off and why it won't fight the melanoma. One way it does that is a molecule called CTLA4, and this new treatment, Yervoy or ipilimumab, turns off this brake on the immune system and lets the T cells or the immune cells grow again and then fight the melanoma. Now, this is another one of those survival curves, and the yellow line is patients that were treated with Yervoy, and the dashed line here are patients that were treated with standard chemotherapy. And what is most encouraging about the ipilimumab or Yervoy is that for some patients they're going into remission for several years after the treatment. Not a big percentage of patients, but some patients do that well, which is achieve very good responses to Yervoy. And there are other similar treatments in development. There's particularly one called PD-1, which Michael might mention, that is looking promising as well. So we have two new treatments available for melanoma, and really looking forward, the thing that I'm really excited about your symposium today, and thank you for inviting me, is that we need a team approach with this disease. We've got a global approach around the world to try to tackle this. The community, everyone here today, people like myself, and industry. There's some industry people here today that make drugs, and government. We all need to work together to do better for this disease. And I'm optimistic, and I think we can talk about that a bit more in question time. Thank you very much.